And Sion, you should have access to share your screen now.
Okay, can everyone see this? Everyone hear me okay?
Yes.
All right, perfect. Hello, everyone. I'm Siyuan. I'm a fourth-year medical student at Cooper Medical School. So I'll be applying for the match this year in neurosurgery. And unfortunately, my partner, Dimitri, he has some schedule conflict, so he won't be able to make it. So I'll be presenting the article by myself. So the article is titled "The Natural History of Vestibular Schwannoma Growth: A Prospective 40-year data from an unselected national cohort." And this is by Redzinski et al. This was published in 2021, and it was published in the Journal of Neuro-Oncology. And this is published out of Denmark. Okay, so we'll get started. Let me click here. Okay, so just give a little bit of background introduction. So as we all know, vestibular schwannomas, they arise from the Schwann cells of the 8th cranial nerve, and they comprise about 80% of all cerebellar-pontine angle tumors. However, when we think about the CPA angle tumors, right, some of the other differentials you want to keep in mind are meningiomas. So they could be petroclival meningiomas. And some of the less other differentials you want to keep in mind is trigeminal schwannomas, facial nerve schwannomas, ependymnomas, and lastly, we always have to keep in mind the possibility of metastasis. So according to the paper, the annual incidence of vestibular schwannomas is about 34 for every million. And the incidence is on the rise. And some have speculated is that with the increasing usage of CT and MRI for working out patients, we're going to find a lot more incidental tumors, not just vestibular schwannoma, but also pituitary adenoma and all kinds of brain tumors. So the risk factors are largely, we don't really know what they are, besides NF2 as a genetic condition, but by and large, we don't really know some of the causes that's driving the vestibular schwannomas. So since this paper really talks about the natural history of schwannomas, we want to go into a little bit more background about their growth pattern and some of the studies that have been done. So this study done in 2010, essentially they looked at a systemic review of all the papers that have talked about the growth pattern of vestibular schwannomas, and they concluded that about VS growth in about 12 to 75% of the time. And they're stable 9% to 75% of the time in the various studies that's being reported. And what's interesting to know is that vestibular schwannomas can also shrink in up to 10% of the observational period, and with some paper even mentioning up to 22%. So this is important when we think about the management, right? So if a patient comes in, we know that from this study, they don't always have to grow. And here's a study by Tika et al. In which they looked at the characteristics of patients with vestibular schwannomas that actually shrinked. So here you can see the MRI from 2008 and 2009. This is the initial image in which they showed a tumor about 3.5 centimeters. And in the following year, the tumor is only about 2 centimeters. So they shown that essentially this case shows you that in the vestibular schwannoma can shrink rapidly in the span of 1 year. And over here, you looked at MRI from 2004 to 2015, and you see there's gradual shrinkage of what is presumed to be a vestibular schwannoma over a gradual period of time. So again, taking home the point that vestibular schwannomas do not always grow. Okay, so let's talk about some of the anatomy, the internal acoustic canal. So the mnemonic always keep in mind 7 up, coke down. So essentially anterior, so this is the IAC, and this is the anterior skull base, and this is the posterior skull base. So when the nerves enter the IAC, the 7th cranial, the facial nerve, along with the nerve intermedius, is anterior and superior in the acoustic canal, and the cochlear nerve is inferior anterior, and the superior vestibular nerve as well as the inferior vestibular nerve are posterior superior and posterior inferior. And here's a diagram out of Neurosurgical Atlas, which essentially shows you that the anatomy, what I had mentioned. And the important thing to know here is that the vestibular schwannoma tumor can grow in different patterns. So therefore, the facial nerve can be distorted in different patterns, depends on the tumor growth. Okay, so now let's talk about some of the goals and management, right? So the goal of management is for tumor control. So in this case, if we don't obtain tumor control, the worst thing that could happen is hydrocephalus and possible herniation from vestibular schwannoma. And as you can see here from a paper, they showed a vestibular schwannoma in this angle, and that was causing ventriculomegaly, possibly hydrocephalus. And after removal, the patient no longer shows ventriculomegaly. And the other thing we want to think about is cranial nerve function, like I mentioned before. If the tumor is compressing on the facial nerve and the vestibular nerve, then obviously there could be a lot of symptoms associated with that. So besides the tumor size, which is one factor, the hearing level, the cranial nerve preservation is another factor. And lastly, what we're going to talk about in this paper really is the potential for tumor growth, right? So as I mentioned, more patients now are coming in with incidental findings of vestibular schwannoma, and the question we have to ask ourselves: what is the best management for those patients? Is it observation? Is it radiation? Or is it surgery? So the study by Carson et al. Using the SEER national database from 2004 to 2011, essentially what they found is that there's a more conservative approach over time by a couple factors. So first, they found that at the time of diagnosis, vestibular schwannoma tends to be smaller compared to cohorts from back in the day. So that indicates that they might not be causing symptoms. Therefore, wait and see approach could be uptaken. And also, more patients are having less microsurgery than prior years. So really, the objective of our study at hand is really to see what happens if we observe these patients for a long period of time. What is their growth pattern and what are the complications that could arise? So here's the method. So a unique thing about this study is that all the patients that are diagnosed with vestibular schwannoma are referred to one national treatment center. So that's what's unique about this study, in that it doesn't have selection bias and it's treated at one national center. Therefore, there's no variations in treatment patterns. So the study is a 40-year period from 1976 to 2016, and all patients with sporadic unilateral VS with MRI imaging are included. Patients are excluded if they have NF2 or if they do not have sufficient follow-up imaging. And here is just a diagram I made. Clinic 1, 2, 3 indicates different parts of Denmark they come from, and they all go to one national center for treatment, which in this case consists of over 3,000 patients. And at that time, the decision was made to either immediately undergo surgical intervention or observe. So if they undergo observation, the tumor is characterized as extrametal, meaning tumor extending out from the IEC into the cerebellar, the CPA angle, or tumors that are purely intrametal, meaning within the IEC without extension into the cisterns. And here we kind of classify them based on the size. So the screening to the study uses that MRI. So at the time of diagnosis, MRI is repeated every year for 5 years. And if they're normal, then an MRI is repeated once every 5 years. And then the criteria for growth is detected as defined as 2 millimeter growth by MRI imaging in the longest diameter of the tumor. Okay, so the paper gives a lot of results, but there are really a few take-home points from this study, and I'll try to highlight them here. So this is the overall cohort, meaning intrametal tumors as well as extrametal tumors. So there were about 3,000 patients that underwent initial observation, and out of which 434 underwent some kind of treatment, in which 372 underwent surgical treatment and 62 underwent radiotherapy treatment, regardless of the type of tumor that was presented. So the overall message here is that 81% of the patients, when they were followed for 40 years, did not require surgical management. Okay, so now let's break down the data a little bit more and talk about what happens if they presented with intrametal tumors or extrametal tumors. And what we found here is that when we look at patients that had intrametal tumors at a presentation, only 11% of them underwent treatment, 10% underwent surgery, 1% underwent radiotherapy. And we observed a total growth of 22% in that cohort. So 22% of the patients with intrametal tumors had growth, but 11% of them underwent treatment for it. And as you can see here. So now let's talk about what happens if you have an extrametal tumor. So if you have an extrametal tumor at the time of presentation, you're more likely to undergo surgery. So 25% of the patients underwent surgery and 4% of the patients underwent radiotherapy. And when you think about the growth pattern of extramedullary tumor versus intramedullary tumor, the growth rate is also higher at 38% at 20 versus 22%. And over 50% of the patients that had growth underwent excision. And here, as you can see here, is a survival curve that was plotted, which over the span of the 40 years, essentially showing that there's a rise. I don't know if you guys can see my cursor, but there's a linear slope, or there's a increasing slope for the 5 years for both tumors that eventually kind of flattens, plateaus at the 10 years, indicating that at 5 years, there's about a 37% and a 21% for a tumor growth, and at 10 years, about 42% and 25%, and that growth rate slows down after 10 years. Okay, so the next graph we want to talk about is that, so this is for all the patients that underwent observation and then subsequently underwent treatment of some kind, or they died. So you can see here is that in the first 12 years, that's where the bar graph lies, and that essentially indicates that if you got a tumor, all of the patients had operation mostly within the first 5 years, and after that, very, very few people got operated on during the years of 6 to 12, and after that, no one really had any surgical intervention after that, which really indicates that tumor growth, if you find someone with a tumor, you follow them for 10 years, and that should be, most patients will receive treatment by that time, or there's no longer growth at that time. And an important thing to know here is that the patients that died in the gray, none of them were related to the cause of death was related to the tumor. They were died for some other causes that are not listed in the paper. So the last graph I want to show here is that when we look at a Kaplan-Meier survival curve with the outcome as indicated as treatment, we see that the patients with extramedullary tumors tend to have a lower 50%, about 70% of them will require treatment by year 10, and most intramedullary tumors do not need treatment with about let's say here 14 years, there's still about 88% tumor treatment free at that time. So just try to talk about some discussion and conclude this paper. So this paper really further validates that the conservative management of vestibular schwannoma is a good approach, right? Because the paper shows that over the span of 40 years, only 11% of the patients actually require treatment, and most of those extramedullary tumors, the tumors that are bigger in size when they presented. So this is great long-term data for us to manage and consult patients, and this is also a proof of practice that I think a lot of the practitioners have already begun to undertaking in the serial follow-up in a span of time. One of the paper did not talk about is that since they have all this data, they didn't really mention whether the increased incidence is truly due to MRI or there's some other cause as to the increasing in the incidence of the vestibular schwannoma. And lastly, last few points I thought were important was that they do mention how many patients had observation initially and how many patients underwent surgery. However, they don't provide the characteristics of those patients that underwent surgery versus the characteristics of patients that underwent observation. Therefore, we don't really know what was their decision making in making those patients with surgery. We presume that the patients that underwent surgery had bigger tumor size, deficits in the cranial nerves. However, they didn't mention any of that. Okay, so this again is a schematic in which they show that if your tumor initially is less than 15 to 20 millimeters extramedullary, you should follow them up. If there's growth, then you should take an individualized approach with respect to hearing, with respect to the facial nerve function, and make a decision as a team. And over here, okay. So in conclusion, so they're doing an average follow-up set of 7.33 years. 22% of the intramedullary tumors and 38% of the extra tumors grew, and only 11% of them needed operation over the entire period. And what's also important to know is that most of the tumors that did grow grew within the first 5 years. And the advantage of this is that it's a long-term study and it's a large cohort that's not affected by selection bias or treatment differences because it's treated at a single center. And lastly, some of the limitations we thought was that the data started collecting in 1976. However, MRI they mentioned was not implemented until 1989. So there's a big gap. I'm wondering how they were able to use CT to distinguish the characteristics of the tumor size because of the lack of sensitivity in cases if the tumor is very small. So the other thing is that they use linear tumor growth to measure the tumor size instead of volumetric study. And in the study, they do addresses the pros and cons of the linear tumor growth versus volumetric tumor growth. And they essentially mentioned that instead of using volume growth, another way to measure tumor growth with following time is really to measure their hearing function and the facial function as another tool to decide whether to continue follow-up or underwent intervention. And that is the slide. Sorry, I rambled on a little bit.
Thanks. It was a great presentation. So now we'll turn over to Dr. Hanft for some discussion and also open the floor to questions from the audience. And if anybody does have questions, please put them in the Q&A so we can keep track of them. Thanks.
Yeah, I thought that was a great presentation. Yeah, it's in a way it runs counter to, I think, probably what your expectations are, as a student, resident, and even as an attending. You think these things are basically ticketed for growth. And then you look at such a big cohort here and you see that growth is actually, in the minority of these cases. So yeah, I think it's like what you said. I think it's fed into this kind of movement towards treating these conservatively, and you really need to be convinced by growth on your surveillance MRIs before you treat these. And that's been a part of my practice. I've been in practice 7 years, so it's not like I've been in practice that long. So I think I've benefited from this kind of consensus or the way in which the field has moved even before, a major study like this. One quick thing I found interesting here was that it seemed like so many of their patients that ultimately did get treatment got surgery. So, I don't know exactly kind of what their criteria are. That's a whole other discussion. They're looking at the natural history of growth here, and that factored in a little bit, but they're mainly looking at whether or not these things grow, when they grow, that kind of thing. But, still overwhelmingly what I'm doing to treat these is radiosurgery, and we'll see that in some of the other presentations. But I thought that was an interesting thing here, that so much of what they did here appeared surgical.
Cool. Thank you. I guess my question would be, if you see someone with like a slight hearing loss, or would you then consider a more aggressive approach? Because I think in this case, the natural history, I'm assuming a lot of them were asymptomatic.
Right. I mean, it's a really good question, right? I mean, this has led to so much kind of debate in the field, and there's so much really left up to you as a neurosurgeon, as a practitioner, kind of where to draw this line and whether to treat or not to treat. Typically for me, I'm very conservative about these. I do agree with the points that you made, and that this paper illustrates that the overwhelming majority of these are incidentally discovered. So then if you say, okay, well, someone has some hearing loss, or let's say they actually had some hearing loss and they got an MRI because of that, should you then treat? It's a fiercely contested thing, and we'll touch on this later too. It varies from case to case, of course. It's kind of a cop-out thing to say. I find myself, though, really needing to be convinced by size and symptoms and growth. Slight hearing loss usually is not enough for me personally. But others will say, look, you're in a better position now to undergo radiosurgery and potentially to salvage that hearing, as opposed to allowing this to grow and developing more hearing loss and then having to get maybe a larger radiation field and potentially fail to salvage what you have. You can, but it's very, very uncommon to improve hearing with radiosurgery. But radiosurgery also can induce hearing loss. So, it's not a guarantee that it's going to preserve what you have. So I tend to kind of really lean away from upfront treatment. I really like to be pushed into it for what would largely be regarded as these kind of minimally symptomatic or asymptomatic tumors. It's a different animal when you get into the larger ones and then have symptoms, and then it can be fairly obvious that they need surgery, but some of those are kind of on the fence as well. But this is just fiercely contested stuff, and I'm sure that when you put this together, you did your own survey of the literature. It's a remarkable amount of literature, remarkable amount of ink spilled about this particular disease type. It's incredible. This particular tumor, it's incredible. And I think part of it also is because it straddles the neurosurgery, neurotology world. So you have ENTs interested in this. And of course, it really straddles the open surgery and radiosurgery world. And a lot of neurosurgeons do both, but you have some real acolytes of both approaches. So you get these, everyone's putting their data together, trying to show what they like to do is better than the other kind of thing.
So I think there was one question from Belina. If you want to unmute and pose your question yourself, you're welcome to.
Yeah, sure. So I was just wondering, when I looked at that Kaplan-Meier curve, how many patients are followed up for 38 years? That's a very long period, right? Especially if these patients don't have symptoms that require intervention. Just a methodological question.
Yeah, I think that's a great question. Actually, I don't have that off the top of my. I don't know if they mentioned this either. But I could look into it and then get back to you on this one.
Usually when I think even you had a slide in there that when you get to a certain point in terms of years of follow-up, a number of MRIs of stability, you fall away. I think in this paper, they mentioned that they did one annually for 5 years and then one every 5. There are variations on this. If I have a small one and it's stable over 3 years, I might go to one every 2. Then I might go to one every 3 or one in a 5-year period. There's no set way. When you're getting into a 38-year window, it's like, that's a long period of time. In fact, MRI is just, I don't know how they were even, outside of probably just some IAC kind of erosion, bony erosion. I don't even know how they were really picking up small vestibular schwannomas on CT pre-MR. Probably what I was just saying, just eroding some of the canal there, and that, because we'll use that even now for some very small, like a facial nerve schwannoma. You can sometimes see a little facial canal erosion on a fine cut CT, but I don't even know if the CTs were good enough to see that. So it's interesting. And you had asked that too in your presentation, what happened between 76 and 89 in this paper.
Awesome. Well, in the interest of time, let's move on to the next group, which is Shelley and Belina, which they're going to present about stereotactic radiosurgery for the high Kuss grade tumors. So you guys are able to share your screen.
Let me see my. Okay, I see it. Okay. So our paper was predictors of long-term tumor control after stereotactic radiosurgery for Kuss grade 4 vestibular schwannomas. It was published in the Journal of Neuro-Oncology this year. So just a quick introduction to it before diving into the gist of this paper. I think it's really important that we know what Kuss grading even is. So for grade 1, it's where it's intracanicular tumor, so it's not really expanding that far. For grade 2, it's minimal extension into the cerebral pontine angle, but it's less than 2 centimeters. So you're not getting, again, as much displacement or compression. And then our grade 3 is when we have it, the tumor occupies the cerebral pontine angle, but it doesn't displace the cerebellar trunk, and it's less than 3 centimeters. In grade 4, which is what we're interested in, is large tumors with brain stem displacement, greater than 3 centimeters. So previously it was thought that you have a large tumor, first line is always going to be surgical resection. And then small to medium sized tumors, it was proven that the stereotactic radiosurgery is safe and effective, but you would never go first line for just the surgical for large tumors. So then the thought kind of developed as to what would you do? Can you do stereotactic radiosurgery for large vestibular schwannomas? And you really want to think about tumor control and brainstem compression, just because there are a lot of people, like elderly people or those with common comorbidities, that surgical resection isn't plausible for them, or they're refusing to undergo surgical resection. So the objective of this paper really was to evaluate predictors for the failure of treating grade 4 tumors with stereotactic radiosurgery and address how to decide if stereotactic radiosurgery would be suitable for the COOS grade 4 vestibular schwannomas before treatment. So in the methods, the inclusion criteria really stemmed upon that there needs to be MRI evidence for brainstem compression. The vestibular schwannomas can only be unilateral, and then the radiosurgery is a gamma knife radiosurgery, specifically with a gamma plan software. There's less than 14 GY to the tumor margin, and a single session of the GKRS is administered to the entire tumor with follow-up period of greater than 5 years. So initially there were 957 patients between 1991 to 2013. And so you could see as it trickles down, and they have their exclusion criteria. So anyone that had a medium size or small to medium size vestibular schwannoma, so anything that wasn't a grade 4 was taken out. Anyone with NF2 was excluded. If they had a different radiosurgery system, so the KULA system, or an increased greater than 14 margin dosage, partial fraction or treatment or fractionation, and then anyone that passed away within the 5 years, they could not be included in the study either. So overall, there were 203 vestibular schwannoma patients who were eligible for this study. So in terms of the indications for the stereotactic radiosurgery, the biggest one, and we'll actually come to talk about this towards the end with the results, was the advanced age of a patient. So you could see that even though the range is from 13 to 83, the median age more skewed upward to 58. And then medical comorbidities, because if anyone ever has medical comorbidities, it is always more dangerous to undergo actual surgical resection. And then patient's preference was taken into place. They specifically mentioned that some patients preferred not to have surgery at all. And so this was an option available to anyone that had the grade 4. So in terms of just basic characteristics of our patients, you can see a little bit more women. We talked about the age. In previous surgeries, you could see a bulk of the patients did not have any previous surgeries or prior surgeries to this. So we have 75% that. And then one important thing to talk about is there was no edema that for 87%. And then they actually looked at House-Brackman grade and Gardner-Robinson grade, which are for like hearing, to see if there's any lack or deficiencies with that, and then other sort of facial signs and symptoms that you may have expected with a vestibular schwannoma. So in terms of our radiosurgical parameters and follow-up, so the biggest thing was, they're all listed here, but was the MCP, so the middle cerebellar peduncle compression. So they show us like kind of a schematic here. It's kind of the distance B to A, so this middle area that's being compressed. And that becomes important when we go into our results. And then what follow-up really looked like was, so first year following the stereotactic radiosurgery, imaging was done every 3 years. In years 2 to 3 following the surgery, imaging was done every 6 months. And then from 4 and onwards, it was just done every year. So in terms of remission guidelines, what they kind of quantified for us was if it was greater than 25% of a volume reduction, it was characterized as a partial remission. Less than 25% volume reduction, they kind of said it was just a stable tumor. And then anytime there was a greater than 25% increase, you're thinking of a tumor enlargement. So to get into some of the statistical analysis and results, so the two factors they were really looking at were tumor control. So anytime there was a tumor enlargement, it was considered a treatment failure. And then we have operation-free survival and salvage treatment. So operations that were included in the if they had these operations, they didn't have operation-free survival. Those were surgical resection and Ommaya reserve placement. Anytime they specifically mentioned if there was like an EV, just make sure I have it right. If there was a hydrocephalus VP shunt placed, that wasn't actually counted in the operation-free survival. And so then we got into some of the numbers as to how follow-up changed with Valina will take over from here.
Yeah, navigate if that's okay.
Mm-hmm.
Okay, so these are some descriptive statistics here. So although we see 203 patients met the inclusion criteria, 3 patients had only baseline images, and so they could not be included in the longitudinal analysis. As we see, the number of patient decreases in this little table below with the longer follow-up, which is what I mentioned in the previous paper. Tumor control and operation-free survival at 60 months. So the primary endpoint was tumor control and operation-free survival at 60 months, and that's what I would highlight in the next slides. But just noting, at the end of the follow-up, 22 patients died, 7 secondary to their tumor. There's complications of the tumor. At the end of the follow-up, 35 patients needed salvage surgery, and out of those, 29 patients required the salvage surgery within the first 5 years. And as Shelley mentioned, 28 patients were lost to follow-up within the first 5 years, and they were not included in the analysis. So we see that tumor control and OFS decrease within the first 60 months at 85% of patients having tumor control and 85.2% of patients, so the bullet points on the right-hand side, having OFS at 60 months. After 60 months, tumor control and OFS rates are more or less stable, as you can see. So they decreased 89 to 85, 85 to 82. There are Kaplan-Meier curves on this, and I did not include them because I did not want to overwhelm the presentations with those. So without dwelling on this much, next slide, please. So moving on to the more interesting analysis. So the authors performed multivariate analysis with age, number of prior surgeries, tumor nature, cystic versus solid, pre-SRS focal edema identified in MRI, and MCP compression as predictors of tumor control and operation-free survival. So MCP compression, which is essentially a surrogate MRI measure of brainstem and cerebellar compression, was the only independent predictor that came out of those multivariate analysis. Receiver operating characteristic area on the curve was used to determine a cutoff of 9.8 millimeters, where MCP compression affected OFS and tumor control differently between the groups. So we can see hazard ratios show that patients with larger than 9.8 millimeter MCP compression were 1.3 times more likely to undergo salvage surgery, and this was significant. And we see on the Kaplan-Meier curve that patients with MCP compression less than 9.8 millimeters have a much higher rate of OFS, and so essentially lower rate of salvage surgery compared to patients with MCP compression that is greater. So essentially, a greater tumor size and compression yields a worse outcome. So this difference was mainly observed during the first 60 months. So as mentioned in the previous paper, the first 5 years is important. And then the rates for both groups after 6.8 years follow-up kind of stabilize and flat out. Sorry. So MCP compression is a surrogate, severe MCP compression is a surrogate for brainstem compression causing lower quality of life due to gait deficits, trigeminal neuralgia, and really bothersome facial numbness. And size of the brainstem compression is useful predictor of SRS outcome. So if we go to the next slide, please. So although in univariate analysis, all variables significantly predicted tumor TC and OFS, age exhibited a trend, not quite a significance in multivariate analysis in addition to MCP compression. And so this was an unexpected result for me as a non-expert. Patients who were older than 48 years had better SRS outcomes measured with tumor control and operation-free survival. Again, we can see how this difference between patients older than 48 in the Kaplan-Meier curves and younger than 48 were demonstrated within the first 60 months. So the slopes are different here. And also older patients had lower rates of salvage surgery and longer and higher operation-free survival compared to younger patients. Oh, but only this was a trend, right? It was not significant. I want to note here that statistical significance, we have to keep in mind as clinicians that statistical significance is very different from clinical significance. And so we need to also look at the numbers, right? Next slide, please. So the authors decided to use both age and MCP compression in classifying patients into high risk and low risk groups. This is getting at the objective of the study, actually, to establish which type of select patients SRS is effective as initial treatment modality. So the high-risk group included patients, as we can see here. So the high-risk group patients younger than 48 with greater MCP compression greater than 9.8 millimeters. Low-risk group were patients with patients who were older than 48 with MCP compression smaller than 9.8 millimeters. An intermediate group are all others. Just a note, this is not described in the patients in the intermediate group, are not described in the article. So I would have liked a little more info on the characteristics of these patients. Anyway, so Kaplan-Meier curves, we see in the Kaplan-Meier curves, we see a significant difference in operation-free survival rate between the low risk and the high risk groups. One also notes that the patients in the intermediate group also have more similar operation-free survival to the low risk patients. So we can see how those curves slope down. Again, by 60 months, we see by 60 months is when this difference is established. So we have 94% of operation-free survival for patients in the low-risk group at 60 months, and that is comparable to 25% operation-free survival in the patients in the high-risk group. So the slopes are significantly different. One thing I want to point out is the initial group size. So the high-risk group, as I mentioned, is only 12 patients, and the low-risk group is 10 times as many. And so once we look at these percentages, they might be different, but in terms of patients, they were just about the same number of patients. So 11 in the low risk and 10 in the high risk. Slides actually on the side effects of SRS, but the most common side effects were trigeminal neuralgia in 11 patients and cysts in 10, and half of those cysts needed to undergo salvage surgery. Most patients requiring salvage surgery developed gait disturbance from cerebellar ataxia, trigeminal neuralgia as mentioned, and facial numbness due to NCP compression or progressive hydrocephalus. Just to note, in Japan, a VP shunt for hydrocephalus is not favored over surgery. And so patients who have hydrocephalus would undergo surgery instead. Just trying to understand and wrap my head around why younger patients do worse than older patients. One reason could be patient selection bias, as younger patients may choose resection as initial surgery and not be included even in these series. On the other hand, younger patients also have less brain atrophy and so less subdural space to accommodate larger tumor burden, and so causing greater brainstem and cerebellar compression with even smaller tumor expansion. Finally, patients who did not experience neurological symptoms in the first 5 years after SRS were observed to undergo gradual tumor shrinkage, as also mentioned in the previous presentation. And so in conclusion, overall, this is a generally well-designed, executed, and reported study. SRS is an acceptable option in selected patients with Coos grade 4 vestibular schwannoma, and risk classification should include patient's age and MCP compression on MRI to inform decision-making for SRS as the primary treatment modality. So this article reports a lot more results in our presentation. I don't think can do it justice, but I hope I highlighted some of the interesting points. Thank you for the opportunity to share this with you.
Thank you both. So we have a few minutes for discussion, but obviously we want to be mindful of Dr. Hanft's time and the rest of the presenters. So Dr. Hanft, I'll let you take it away.
Yeah, I like this study, and I thought that was a great presentation. I just found it interesting because it seemed more of like an envelope pushing study, you know, and that they're radiating things that are traditionally considered kind of off limits for radiosurgery just based on size. So I thought, for me at least, I found it interesting how they quantified middle cerebellar peduncle compression, and you know, as kind of a mechanism and it was really a pivot point regarding you know, overall survival and tumor control. So I found this study to be pretty cutting edge, you know, to the real traditionalist skull-based surgeons, which I do not count myself among. This would really be kind of heresy to even consider doing radiation to these kinds of tumors. But for guys like myself who regard themselves a little bit, you know, very much more on the conservative end of the spectrum, it really, you know, it's validating and it really should be an eye opener. I mean, there's quite a bit of good data here, over 200 patients, and they're doing radiosurgery in single shot. They're not even fractionating this to these very large masses. Would have been interesting, I think. I don't really remember, when I looked through it, I don't really remember seeing any MRI images that they provided. Would have been nice to have seen a few, because it's one thing to look at the volume, the dimensions, it's another thing to really kind of see an MRI, a sample MRI or two of what they were radiating. But I guarantee they're radiating things that you know, people here would be operating on in a heartbeat. So I think it's just very important. You know, the take-home point for me, you know, for me at least, is that there is a role for radiosurgery in tumors that would traditionally be considered completely off limits based on size parameters and degree of middle cerebellar peduncle compression or brainstem compression. Just so you guys know, really even a whiff of that compression, forget kind of dimensionalizing it with this accuracy, even a whiff of that compression would typically qualify someone for surgery, disqualify them for radiosurgery. So the fact that they're getting into the weeds to this level and talking about 10 millimeters of compression, which is a lot, and getting away with it, pretty remarkable. So I'm into it. Would I incorporate this into my practice? Probably, because I personally am very forthcoming about the morbidity of this surgery, and even in my hands, having done a lot of complicated ones, the rate of facial nerve weakness is high. And I think it's a hard thing to gloss over. And a lot of the skull-based surgeons who publish on this gloss over it, but I'm not saying that in a critical way. Let me put it this way to you guys. I think that I think that nowadays, vestibular schwannomas that qualify for surgery are rare. They're large, they're compressive, they're difficult to remove. And if you're only operating on those, which the new generation really should only be, right, because of SRS, how good can you get at doing one or two of these complicated ones a year where the facial nerve is basically unidentifiable? How good can you even get at facial nerve preservation? It's very difficult. For these other guys who've been doing it for 20 to 30 years, who are operating on 1 centimeter tumors, where the facial nerve is very easy to preserve, they could kind of translate that skill set into these larger tumors. So this, I think, is a very, like I said before, envelope pushing, forward thinking kind of study where it's going to only become increasingly more difficult for you guys who are going to come up through the ranks in the next 10, 20 years to really get good at removing these very large tumors. It's hard. So if radiosurgery is effective, even in this subset, that's a very good sign. It may not be what you want to hear because there's glory to removing this large kind of tumor. But I mean, what I'm telling you is there's not that much glory because it's very hard. It carries quite a bit of morbidity. And I, at least now, 7 years into my practice, if I had an acoustic neuroma, I'd be praying that I could get SRS in that surgery. So I would probably bring this paper to whoever my neurosurgeon was, saying, let's do radiation.
Yeah, I think that's a good point, because at the end of the day, you want positive patient outcomes, right?
Oh, yeah. Yeah, I mean, it is very difficult in these 4 to 5 centimeter acoustics to get meaningful facial nerve preservation. I'm telling you guys that. I mean, I know what the literature says. I know that handful, and I'm not saying that people who are doing this stuff are lying, but you got to look at the background. You got to look at people who are operating for a long period of time, have operated on smaller ones. Those are the people who are getting into the literature. It's very difficult to get someone through an acoustic neuroma operation of 4 centimeters scot-free with intact facial function. It is very difficult. And I do a lot of hard tumor surgery, and I think it's one of the hardest things to do in all of tumor surgery. So, yes, and one thing you see in this paper, one thing we know, SRS, you just don't get that facial weakness. And we hem and haw about having to shunt, which was still a very low incidence here, but shunting and radiating, I think, is vastly preferable to a complete facial paralysis. You know, if you're able to get that person, you know, and there are other things that come along with removing these tumors surgically beyond just facial paralysis. I mean, in fact, in the name of decompressing the middle cerebellar peduncle and the brainstem, there are times where you cause quite a bit of cerebellar injury, prolonged retraction, vascular congestion that ends up, you know, whatever it is, stroke, contusion. These people end up having a component of ataxia as is. So, you know, I think it's a cool paper. I think it's one of the, you know, I'm almost amazed that a paper like this exists, because, like I said, it's got to come from another country, because which it does, because the incentive to operate is just a little higher in the United States than it is elsewhere. It's harder to imagine this study happening here, that there be a restraint, because people love doing skull-based surgery. I don't think it's necessarily relished the same way elsewhere, and financially, right? There's a big difference, and not that radiosurgery is cheap. It's not, but it's probably half the price of doing one of these big skull-based operations. So, but a fascinating paper for sure. Very compelling.
Awesome. So why don't we move on to the third group, which is Sanjami and Caitlin, and they're going to be presenting a paper on dose rate effects related to SRS for vestibular schwannomas. So take it away.
Wonderful. Thank you for the introduction. Yeah, so I'm Caitlin. I'm a current postdoc fellow and M3 at the University of Missouri School of Medicine. I'll be presenting me, who's an M2 at this, and the letter is the original paper that was titled "The Treatment Outcomes and Dose Rate Effects." following gamma knife stereotactic radiosurgery for vestibular schwannomas. Again, this was published in 2019 by the Journal of Neurosurgery. Okay, the first part of this presentation, I will focus on introducing gamma knife stereotactic radiosurgery, as well as kind of the key points from the original paper. Okay, so to start off, so gamma knife stereotactic radiosurgery, it's going to deliver radiation using spontaneously emitting radioactive cobalt-60 with a half-life of about 5.6 years. And again, with this, typically it's going to be a measure that's going to reflect the speed of the radioactive decay. And again, one of the shortfalls with this is that the actual rate of how quickly fixed the radiation doses are delivered during the gamma knife radio surgery is going to vary across the lifespan of the cobalt sources. And so if you just want to look over at the diagram on the right-hand side, so this is the gamma knife machine. It's going to be housed in a thick lead unit, and the sources are actually going to be arranged concentrically kind of around this helmet. And they're also going to be oriented to deliver the radiation to a single point, which is going to be referred to as the isocenter. And the radiation is going to, again, it's going to be modified by these circular collimators, which is going to be located inside the helmet. And they're also going to have various diameters. So the indications for the gamma knife stereotactic radiosurgery are going to be typically poor operative candidates. So these are often going to be patients that have poor medical conditions or advanced age, and it kind of varies. So the range that I kind of saw in the literature was about 65 to 70 years. Patients who have bilateral vestibular schwannomas, as well as post-operative treatment of an incompletely removed vestibular schwannoma, or if they have recurrence following surgical intervention. And just so a little bit more about the gamma knife. So they're going to use these different size collimators as well as exposure times. And typically they're going to use more than one isocenter, as well as the plugging collimators that are going to kind of help pass this radiation through these sensitive structures. And there's also some alternative treatment modalities. So the original paper kind of compared the gamma knife stereotactic radiosurgery to the microsurgical resection. So nationwide, the microsurgery is going to remain the most commonly approached therapy for vestibular schwannomas. However, the stereotactic radiotherapy, it's obviously less invasive. And also what they reported in this original paper is that it's going to maximize the likelihood of short-term hearing preservation. They can also do proton beam therapy as well as linear accelerator-based treatments as well. And then the paper highlighted actually, so two different gamma knife machines. So they look specifically at the model B as well as the Perfexion. So again, this is just kind of showing a timeline where there's been a continuous upgrade over time of these gamma knife machines. So moving on to the reference dose. So the reference dose rate in gamma knife radiosurgery is actually going to be measured at the center of a 16 centimeter diameter phantom. And they're going to actually use the largest collimator. But the key thing here is it's not going to actually be the actual dose rate in the target. So even at the prescription isocontour, the dose rate will typically vary to a number of factors. So namely is going to be the head size, as well as the collimator size, and then the number of beams that are going to be blocked. And then the key thing is in vestibular schwannomas, they're often going to have multiple isocenters, and these are going to be summed to give a prescription isodose. And each isocenter is going to differ in its dose contributions depending on the location, size, and weight. And then another important point is between these isocenters, the dose rate will be 0 when no damage is produced, but you do have repair occurring. And so there's going to be gaps in the treatment that are going to contribute to the total treatment time. So specifically in the original paper, when they looked at the model B gamma knife, the gaps were on the order of minutes compared to the newer model, which is the Perfexion, where it was on the order of seconds. And I included this image on the right. So this is a right acoustic schwannoma. It's going to be seen on a T1 MRI post-contrast, and the patient is receiving a marginal dose of 12 gray units. And again, they're going to be utilizing the gamma knife stereotactic radiosurgery. But as you can see, the green circular lines are showing the isodose lines used for this procedure. Okay, moving on to the biological effective dose, or BED. So the average BED of a given treatment is going to be related to two factors. So the overall treatment time and also the physical dose. So the ranges of the BED values are going to reflect the differing dose contribution per isocenter to the total prescription dose. And one important factor to keep in mind is that this is going to widen when the larger numbers of isocenters are used. And then another key point is that both papers refer to the calculation of the BED values. And again, those are going to be associated with differing doses from each isocenter at each voxel, which is pretty complex. So they have a solution. So they were able to make a first order approximation based off of this mean BED for a particular prescription isodose. And then the image on the right, this is a representative MRI images from the midplane of two vestibular schwannomas, and they're going to be treated with the Model B gamma knife. So you can see in the left-hand side, so they're using 3 isocenters in comparison to the right, where they have 13 isocenters. And then below is going to be the equation for the biological effective dose with the external beam radiation therapy. And so it's going to be, the N is going to be the number of fractions. You're going to multiply that by the dose per fraction. And then you'll take 1 plus the dose per fraction divided by the alpha and beta ratio, which again, that's going to be the dose given. So moving on to the original paper. So the original paper was published by Smith in 2019. And the key findings with this paper really focused on the purpose of the study, which was to evaluate both the efficacy and then also the potential dose rate effects on the clinical outcomes following the definitive gamma knife stereotactic radiosurgery for vestibular schwannomas. And so the figures that were highlighted in the original paper looked at the impact of the treatment dose based on the post-treatment outcomes. And so on the figure 1A, so that's highlighting the clinical tumor control, as well as figure 1B, which is a radiographic tumor control. And they used the Mantle-Cox log rank test. But what they found is that the rates were similar between the lower and higher dose rate groups. And so the lower dose rate group was less than 2.675 gray units per minute. And then the other key findings, so while they found that the gamma knife stereotactic radiosurgery patients that were exposed in figure 1C, you can see to the lower treatment dose rates, so again, less than 2.675 gray units per minute, it was associated with an increased risk of developing progressive post-treatment hearing loss, as well as facial nerve dysfunction. And then also they found that the larger pre-treatment maximal tumor diameter did appear to be protective. And then just a couple key takeaways from the original paper before Sangamai takes over with the letter in response to this paper, was that the gamma knife stereotactic radiosurgery provided an effective tumor control independently of dose rate in their study. But again, patients that were exposed to these lower dose rates experienced significantly better freedom from post-treatment hearing loss and facial nerve dysfunction. And they reported that the gamma knife stereotactic radiosurgery provided excellent tumor control as well as effective symptomatic relief. But the key thing here is going to be the dose rate effects. So those can impact post-treatment functional outcomes. And then also the lower dose rate exposure, it can result in a lower bed within both the tumor and the surrounding normal tissue. So that can impact the tumor control as well as the post-treatment toxicities. And I will hand over the rest of this presentation to Sangamai. Thank you.
Awesome. Thanks, Caitlin. So now we're going to transition to the letter that we are going to discuss here, and it's titled Treatment Outcomes and Dose Rate Effects Following Gamma Knife Stereotactic Radiosurgery for Vestibular Schwannomas. So the main point here is that they are responding to the original study that Caitlin discussed by saying that the dose rate itself is not intrinsically important. Rather, the critical point is that the dose rate influences the time over which the given radiation dose is delivered. And this is important because the longer the period of exposure, the greater the degree of repair of the cells, and hence the lower the biological effectiveness of this dose. And so that's really important to keep in mind, and their major point in response to the original paper. And the study reports that dose rates usually should be referenced in terms of the dose rate on the cells or the tissue in question. And the original study discusses dose rate from the actual gamma knife machine rather than the dose rate that's actually affecting the cells. And like Caitlin mentioned, the dose rate actually affecting the cells is dependent on various things like the large collimator, the head size, the number of beams, etc. And so that's really important to distinguish between the dose rate that's coming from the actual gamma knife versus the dose rate that's affecting each cell. And actually, interestingly, in 2019, there was a paper published showing that in vitro, the survival of cells is influenced by a variation in treatment time, irrespective of dose. And although that's in vitro, it could have implications for human gamma knife surgery. So next slide, please. So going back to what Caitlin mentioned about bed, the biologic effective dose, the norm for treating vestibular schwannomas with gamma knife is to do a treatment with multiple isocenters, and those summed together give a prescription isodose. And this is really important because we need to understand that the prescription isodose is means that the dose rate is going to vary both temporally throughout the treatment as well as spatially throughout the target. And like Caitlin mentioned, the model B has larger gaps in the middle of those isodose treatments on the order of minutes, whereas the Perfexion has gaps on the order of seconds. And so, like Caitlin mentioned, this is the bed equation that is able to estimate those things, and it relates the overall treatment time and the physical dose, which is both important, not just either the treatment time or the dose. Next slide, please. Awesome. So this is the figure that they show in the letter. And so to orient you, the top figure is looking at the dose in terms of 12 grays, and the bottom is 13 grays. And the x-axis is looking at total treatment time, and the y-axis is the percentage of cases. And so the darker bars that you see on this graph is a lower dose rate versus the lighter bars with the lines is a higher dose rate. And so it's really important here to make the point that treatment delivery time is what really modulates the dose delivered, and it's best described by using the concept of bed. And so you can see that although there's significant overlap in the treatment time between the lower dose rate and the higher dose rate, it's not perfectly overlapping. And it's important to take into consideration this difference and accounting for treatment time, not just dose rate. And again, a nuanced point here is that this figure is combining both model B, they had an N of 58, and the Perfexion gamma knife, which was an N of 48. And they're combining those models and those treatments into this figure. So, we can't really see the difference between those models, and perhaps these graphs would look different if they were separated based on model. Next slide, please. So here is the table that they presented in the letter as well. And so what this is looking at is they selected cases that gave similar overall treatment times of around 55 minutes, and they recalculated for reference doses of 1 grays per minute, 2 grays per minute, and 4 grays per minute. And you can see, again, they had two different gamma knife models, again, the model B and the Perfexion models, and they describe the number of isocenters as well as the treatment time, which they're all around 55 minutes, ranging between about 50 and 60 minutes. They calculate the mean bed as well as the bed range here. And an important point here, is that the range of bed values, the range of bed values reflect the differing dose contribution per isocenter. and that to the total prescription dose, which tends to be wider when there are larger numbers of isocenters used. For each, and in addition, for each dose, the mean bed values were similar, although the reference dose rate was varying by almost a factor of 4, so 1 to 2 to 4. So this is just showing that although this reference dose rate is changing on from 1 to 2 to 4, the mean bed range as well as the bed range are both pretty similar. And so again, this shows that, although the dose rate is different, the actual dose being delivered to the target is not going to have a large difference. And so you can go to the next slide, Caitlin. Just kind of final takeaways from this letter is that, you can't just look at dose rate from the actual Gamma knife itself. The critical point is that the time over which the radiation dose is delivered is very important, and as well as others, several factors. This is important generally when you're looking at clinical outcomes. It's obviously not going to be based on one specific parameter, as well as looking at sublethal damage repair. This is very important, and the literature has looked at some of these things in terms of radiosurgery and its effect on damage repair in cells. And then in addition, the bed concept that we've discussed here is very important, and it illustrates that treatment delivery time modulates the dose delivered. And another nuance point here to make is that it's hard to calculate the bed values associated with the differing doses from each isocenter at each voxel, because the shot dose per voxel is usually not available. But there was a recent publication in 2018 that has made way to make a first order approximation of the mean bed for the prescription isodose. So that is something that, is up and coming, and hopefully we'll hear more about in the future. And kind of to round this out, there are many future applications of the concept of bed, biologic effective dose, and on the clinical outcomes of various pathologies treated by Gamma knife. I think some of the limitations of this is obviously it's just a letter. It's not a full, retrospective or prospective analysis of a large cohort. So it's important to keep that in mind. But I do think that they make a good point on, you can't really narrow down the outcomes to just the higher or lower reference dose, but looking at different things like treatment time, using these modalities such as the bed value, and potentially looking at bed values per voxel in the future is definitely going to be important. So we'd be happy to take any questions. Thank you.
Thank you, guys. So yeah, we have.
Hey everyone, Ryan Rad here from neurosurgerytraining.org. If you like that video, subscribe and donate to keep our content available for medical students across the world.